Hey guys, welcome back. Now, in this class, I'm going to start with the AMAT path. Okay. Now, in this class, I'll be starting with the RBC disorders. In the later classes, we'll be discussing about the platelet disorders as well as the WBC disorders. Okay. Now, in this class, let's begin with the RBC disorders. The main RBC disorders that everyone knows is anemia. So, how many types of anemia are there, sir? There are three types of anemia: microcytic, macrocytic, and normocytic anemias. So in this class, let's try to complete as many anemias as possible. Let's try to discuss like what are the main pathologies involved in this development of these anemias. Okay. Having said that, now without any further late, let's begin our topic RBC disorders. See, in the RBC disorders, first the topic I am taking here is anemias. Okay. So what exactly is anemia, sir? Okay. So anemia in males. So in males, the hemoglobin, okay, the amount of hemoglobin, if it is less than 13.5 grams per deciliter. So in the male, if the hemoglobin level, if it is less than 13.5 grams per deciliter, deciliter means 100 ml. So in 100 ml of blood, okay, in 100 ml of blood, if the hemoglobin, if it is less than, if the hemoglobin, the pigment, okay, the pigmented protein, if it is less than 13.5 grams per deciliter, then it should be considered as anemia in the males. The same females, if the hemoglobin, if it's less than 12.5 grams per deciliter, in females, sir, if the hemoglobin is less, if it's less than 12.5 grams per deciliter, then it's considered as anemia in females. So once a patient is having anemia, what kind of symptoms are going to be seen in the patient? Okay, imagine I'm the one who is having anemia. So what kind of symptoms are going to be seen? It's the hemoglobin which is bringing the oxygen to the tissues. When less amount of hemoglobin is there means definitely there is going to be hypoxia. Anemic hypoxia is going to occur, right? So the patient is going to have hypoxic symptoms. Okay, the patient is going to have hypoxic symptoms. So what are these hypoxic symptoms? So the oxygen is not properly getting delivered to the tissue. The enough amount of oxygen is not properly going to the tissues. So hypoxia is there. So the hypoxia symptoms are going to be weakness. Very easily the patient is getting weak and fatigue. Okay, weakness or fatigability, easy fatigability. Okay, easy fatigue. The patient is going to have easy fatigue, and the patient is going to have a dyspnea kind of symptoms. Okay, dyspnea kind of symptoms are going to be seen. The patient is going to have headaches, lightheadedness can be seen. Okay, lightheadedness. See, the point which I want you to know is, so these symptoms are going to be the same. The symptoms are going to be the same for all kinds of anemia. It doesn't matter whether the anemia is a microcytic anemia, macrocytic anemia, normocytic anemia, megaloblastic anemia. It doesn't matter. When the person is having anemia, the patient is going to have same this. Okay, that's okay. Yes. So sorry for the technical glitch, guys. Sorry for the technical glitch. What exactly I'm discussing about here is about this anemias. Okay. So the anemia in the males is less than 13.5 grams of hemoglobin per deciliter. Anemia in the females is less than 12.5 grams per deciliter. Okay. So anemia in males and females. If a patient is having anemia, the patient is going to have hypoxic symptoms. That's what I have discussed. Okay. So what are the hypoxic symptoms I have given here? The patient is easily getting tired. Okay. Female is going to say, sir, I'm getting tired very easily. Okay. These are the things. Now, how many types of anemia are there? See, based on the RBC size, the size of the RBCs, okay, the size of the RBCs. See, the size of the RBCs is normally measured in femtoliters. The size of the RBCs is measured in femtoliters. The volume of the RBCs is measured in femtoliters. So, the usual size of the RBCs is 80 to 100 femtoliters. Okay, usual size. That's the usual size of the normal RBCs. If the RBC size, if the RBC volume, I should say, if the RBC volume, if it is less than 80 femtoliters, okay, if it's less than 80 femtoliters, which means the RBCs are becoming smaller. Now these are the smaller RBCs, sir. Now when the RBCs are smaller, then those kind of anemias are called as microcytic anemias. Microcytic anemias. Okay, they are called as microcytic anemias. So RBC size, if it is less than 80 femtoliters, microcytic, chota RBC, small RBCs. Okay. Now, if the RBC size, if it is greater than 100 femtoliters, okay, big size RBCs, now they are humongous RBCs. So the anemias in which the size of the RBCs is increasing, so such kind of anemias are going to be called as macrocytic anemias. Okay, macrocytic anemias. And there are anemias where the size is normal, sir, 80 to 100 femtoliters. Okay, there are anemias where the size of the RBCs is in a quite normal range. So such kind of anemias are called as normocytic anemias. Okay, normocytic anemias. So anemias are of how many types? There are 3 types of anemias. What are they? Microcytic anemias, macrocytic anemias, and normocytic anemias. Okay, macro, and normocytic anemias. So based on what? Based on the volume, based on the volume of the RBCs. Big RBCs, small RBCs are normal sized RBCs. Now without any further late, now let's begin our first topic, that's the microcytic anemias. The microcytic anemias, kya hai? What exactly are these microcytic anemias? In the name itself it's there, microcytic means small RBC, small RBCs. That is less than 80 femtoliters, less than 80 femtoliters, okay, 80, not 8, 80 femtoliters. Okay. Now my question is, why small RBCs? Why small RBC? Okay, why small? Okay, why small size RBCs? For example, let's put it this way, sir. Okay, let's put it this way. Now imagine there are 10 people. Okay, in your family there are 10 people. You need a bigger home. If there are only 2 people, you need a small home. That's a basic logic, right? In the same way, when do you need a normal size RBC? When normal amount of hemoglobin is there, normal volume of RBC. If the amount of hemoglobin is going down, okay, the amount of hemoglobin is going down, the hemoglobin is getting down, sir. So less amount of hemoglobin, less amount of hemoglobin production. Why less amount of hemoglobin production? I will tell you. Okay, sir. Now less amount of hemoglobin is there, sir. So because of less amount of hemoglobin, RBC size also small. So that's why microcytic. Now, as there is less amount of hemoglobin, what do you think? RBCs are going to be good red in color, or are they going to become pale color? So RBC, so hemoglobin production is decreasing. So the RBCs are going to look pale color. So hypochromic RBCs are seen. Hypochromic. Chromic means color. Hypochromic RBCs. That's a pale RBCs. Pale. Okay. So hypochromic, microcytic. Hypochromic, microcytic RBCs are going to be seen in microcytic anemias. Now the question is, why less hemoglobin? Why hemoglobin is less? Hemoglobin is less, that's why RBC size is also less. But the question is, why hemoglobin is less? Hemoglobin is less because you should understand, first of all, what is hemoglobin, sir? First of all, see, what is hemoglobin? So hemoglobin, it's a protein, it's a pigmented protein made up of heme plus globin. Heme plus globin. Okay, heme and globin, sir. So what is this globin? So globin, it's a protein. Okay, globin is made up of alpha globin chains, beta globin chains. Globin is a protein, sir. Okay, it's a protein. Simple. So, okay, which is made up of, globin is made up of alpha globin chains and beta globin chains, alpha globin, beta globin chains. So then what is this heme? The heme is made up of 2 things. Heme is made up of iron and protoporphyrin. iron and protoporphyrin. Okay, now see, you need to understand why microcytic anemias. Why microcytic anemias? Maybe one reason is iron deficiency. Sir, when iron is deficient, okay, when iron is deficient, heme synthesis is not going to be there. Without heme, hemoglobin production goes down. Simple. Second thing, sir, protoporphyrin production. Okay, the protoporphyrin ring. There is a protoporphyrin ring, sir. Okay, so there is a big pathway for the production of this protoporphyrin. If this protoporphyrin is not getting produced, again heme is not going to be there. Without heme, no hemoglobin. Okay, so you can have iron deficiency anemia, possible. You can have defect in the production of the protoporphyrin. So without protoporphyrin, where iron will go? Iron is not going to bind with anything. Iron is simply staying within the cells. That will cause sideroblastic anemias. Okay, so protoporphyrin deficiency will cause sideroblastic anemia. Iron deficiency will cause iron deficiency anemia. And sir, globin chains, the globin, alpha globin and beta globin chains are not there. Okay, insufficient, not sufficient, sir. The globin protein is not getting produced. Sir, the globin protein is not getting produced. Again, without globin, there is no hemoglobin. So that will cause what? Thalassemia, sir. That will cause thalassemia. Thalassemia is the defect with the globin chains. Okay, where there is not enough globin, where there is not enough globin. Okay, so these are the different causes of decreased hemoglobin production. Without hemoglobin or with a little amount of hemoglobin, small RBCs. That's the microcytic RBCs. Okay, as simple as that. So without any further late, now let's begin our topic, microcytic anemias or the causes of microcytic anemias. There are 4 important causes of microcytic anemias. Okay, 4 conditions. In 4 conditions you will see microcytic anemias. What are the 4 conditions in which you will see microcytic RBCs, small RBCs? One is iron deficiency anemia. Iron deficiency anemia. Okay, where iron is not there. Second one is sideroblastic anemia. Sideroblastic anemia. What's the defect, sir? Sideroblastic anemia, it's a protoporphyrin is not there, not available. Next, third one is thalassemia. Thalassemia, sir. So in thalassemia, where is the problem? It's a globin, a deficiency of the globin chains. And one more condition is there, which is called, as I will explain you, anemia of chronic disease. Anemia of chronic disease, sir. So anemia of chronic disease is something seen in the patients who are hospitalized. Okay, the patients who are having a chronic infections or chronic inflammatory conditions. In those people, you will see the anemia of chronic disease. I will explain you, don't worry. So without any further late, now let's begin our topic with iron deficiency anemia. Okay, so first microcytic anemia that I am talking here is iron deficiency anemia. So iron is not there. Okay, iron deficiency anemia, sir. Now, iron deficiency is the most common nutritional disorder. Okay, the most common nutritional disorder, sir. Now, the point which I want you to know is why a patient can get iron deficient. Okay, why a patient can get iron deficient. So before I am telling you before telling you why a patient get iron deficient, let me tell you some important points about the basic iron absorption. Okay, basic iron absorption. See, there are 2 forms of iron, sir. 2 forms. Okay, there are 2 forms of iron. One is ferric iron and ferrous iron. Ferric iron and ferrous iron. The ferric iron you will get it especially from the plant sources, and ferrous iron you will get it from animal sources. Okay, so animal sources will give you a ferrous form of iron, that is Fe2 plus, and from the plant sources you will get Fe3 plus form of iron. See, this ferrous iron, okay, this ferrous iron, this is readily absorbed. Okay, readily absorbed. You can easily absorb it. You can easily absorb it. But Fe3 plus form of iron is not absorbed. It's not absorbed. It's not absorbed. Okay. So who is going to be having problem? Vegetarians or non-vegetarians? So it looks like the vegetarians are going to have the problem because they are getting Fe3 plus form of iron, and this Fe3 plus form of iron is not going to be absorbed. But in reality, there is not going to be any problem. There is no problem, sir, because you should understand. See, this Fe3 plus form of iron will be converted into Fe2 plus form of iron. The Fe3 plus ferric form of iron is converted into ferrous form of iron with the help of what? With the help of acid in the stomach. So the acid in the stomach converts ferric iron to the ferrous iron. Okay, even so, vegetarians, if they take Fe3 plus form of iron, that will be converted into Fe2 plus form of iron. So now this Fe2 plus form of iron, now this is in the duodenum. Okay, now imagine this is the duodenum, sir. Now here we have Fe2 plus form of iron. Now this Fe2 plus form of iron need to be absorbed. So this is the duodenal enterocyte. Okay, now this is the duodenal enterocyte. Now on this duodenal enterocyte, there is a transporter present. Okay, there is a transporter present, sir. This transporter, it is called as DMT1. Okay, DMT1. So with the help of this DMT1 transporter, iron is coming into the cell. So name of this transporter is DMT1, divalent metal ion transporter 1. With the help of the divalent metal ion transporter 1, Fe2 plus is coming into the cell. Now from the cell, now the iron have to come where? The iron have to come into the blood. Okay, it have to come into the blood. We don't want the iron in the cells. We don't want the iron in the enterocytes. The iron have to come into the blood. From the blood, iron have to go to the bone marrow for the production of hemoglobin. The iron have to go to the liver where it's a storage site. So this iron, see, now it is coming out of the cell. It's coming out again with the help of one more transporter protein. So this transporter protein that I am highlighting here, this is called as ferroportin. So with the help of this ferroportin, iron Fe2 plus, it is coming out. So it's coming out, sir. But in the way, okay, the Fe2 plus form of iron will be again converted back to Fe3 plus form of iron. Okay, with the help of something called as a hephaestin, there is something called as a hephaestin which will convert Fe2 plus form of iron to Fe3 plus form of iron. On the surface, there is something going to be hephaestin which converts Fe2 plus to Fe3 plus back again. So now this Fe3 plus form of iron is coming to enter into the blood. Okay, Fe3 plus form of iron is going to enter into the blood. Now this iron is just like a naughty boy. Okay, he's just like a naughty boy. What naughty boys will do? Naughty boys will go after all the girls. Okay, so this Fe3 plus, this is also a free radical. It's a free radical. As it's a free radical, it will react with the water. It will, and like there is something called as a Fenton reaction. It generates the free radicals, and these free radicals will react with the cell membranes, causes the damage. So we are not supposed to leave this iron in the free form. So this iron need to be bound. Okay, you need to capture this iron, sir. Actually, okay, the iron need to be captured. So who is capturing it? It's a plasma protein. What is the name of this plasma protein? This plasma protein to which the iron is bound, it is called as transferrin. Transferrin. Now this transferrin, it transfers, in the name itself it's there. See, the transferrin transfers the iron to the bone marrow. Okay, it's giving the iron to bone marrow, sir. Okay, this is bone. Okay, iron is coming here to the bone marrow. In the bone marrow macrophages, the iron is going to be stored. The iron is going to be stored in the bone marrow macrophages, sir. And where else the iron will go? The iron will also come to the liver. The iron will also come to the liver, sir. Okay. So where the iron is getting stored? So where the iron is getting stored? So iron is getting stored in the bone marrow, and the iron is also getting stored in the liver. So in the bone marrow as well as the liver, the iron is getting stored. Done. In which form? In Fe3 plus form. So this iron which is stored in the body, these iron stores are called as ferritin. Okay, these iron stores are called as ferritin, sir. Okay. So these are the points which I want you to know regarding normal absorption of the iron. Okay. Yeah. Next, say, let me again tell you simple important points. Iron is getting absorbed in the duodenum with the help of DMT1. The iron is coming into the blood with the help of the transporter called as ferroportin. Now in the blood, iron is bound with transferrin. Transferrin transfers the iron to bone marrow macrophages as well as liver. What is the storage form of iron? Fe3 plus. The storage iron is called as ferritin, sir. The storage iron is called as a ferritin. Now, let me tell you why someone get iron deficiency. Okay, iron deficiency. Let's write here, iron deficiency. Why someone get iron deficiency? What might be the reason? So I have already said you, iron deficiency is the most common nutritional disorder in the world. It's very easy that one can get into the iron deficiency. Iron deficiency can be seen in adults, especially with the peptic ulcer disease. Peptic ulcer disease. So peptic ulcer disease means these ulcers will bleed. Okay, the ulcers is going to bleed. That bleeding will come out in the form of hematemesis or either melena. Okay, the peptic ulcer disease can cause. Second cause of iron deficiency can be seen in infants who are breastfeeding. So infants who is breastfeeding, so the milk is deficient in the iron. The milk is deficient in the iron. So the infants who are totally and exclusively breastfeeding, they might end up in iron deficiency. Peptic ulcer disease is one reason. Or the patient who is having a colon cancer, okay, colon cancer or polyps in the colon, which can lead to bleeding. So colon cancer. So these cancers, they will bleed, okay, or polyps. These polyps, especially the rectal polyps, okay, juvenile rectal polyp, they will bleed. This rectal polyposis, they can bleed and they can lead to iron deficiency. See, bleeding means what? The person is bleeding. The person is bleeding means the person is losing the iron. Why? Because bleeding means that he is losing the RBCs. He is losing the RBCs, he is simply losing the iron cell. Why? Because in the RBCs, hemoglobin is there. In the hemoglobin, iron is there. Okay, so iron is going out of the body. So any hemorrhagic condition can lead to iron deficiency. Okay, and certain parasites, okay, certain parasitic infections like ankylostoma, duodenal, ankylostoma duodenal, sir, in the name itself it's a duodenal, it's going to live where? It's going to live in the duodenum. The duodenum is the site where iron absorption occurs, sir. This is the duodenum, sir. So in the duodenum, the iron absorption occurs. For example, here, if the parasite is living means that parasite interferes with the iron absorption. Parasite is going to cause the inflammation. So it interferes with the iron absorption. So parasitic infections like ankylostoma duodenal can lead to iron deficiency. So breastfeeding in infants, the breastfeeding in infants or in adults, peptic ulcer disease, and females, especially females, are at a more risk of getting this iron deficiency. So females will get the anemia, right? Most of the time females are going to have the anemia. Do you know why? Sir, during menses, if they lose more blood, okay, that is menorrhagia. Okay, menorrhagia, sir. So the patient is having menorrhagia, that is excessive blood loss, that can also lead to iron deficiency. Okay, so peptic ulcer disease, menorrhagia, breastfeeding, colon cancer, ankylostoma duodenal infections, all these are going to cause the iron deficiency in the person. And not only that, sir, if you use certain drugs like proton pump inhibitors, okay, let me add here proton pump inhibitors. So what are these proton pump inhibitors? Proton pump inhibitors like omeprazole, okay, pantoprazole, esomeprazole, these drugs, okay, Zolzo, okay. So proton pump inhibitors, what they will do? They decrease the acid production, okay, they decrease the acid production. So acid is the one important thing which helps in conversion of Fe3 plus to Fe2 plus, Fe3 plus to Fe2 plus. So if you give proton pump inhibitors, acid is going down. When acid is going down, the conversion of Fe3 plus to Fe2 plus decreases. The conversion decreases. Now Fe3 plus is not getting converted into Fe2 plus. So iron absorption decreases. Iron absorption decreases. So proton pump inhibitors can cause iron deficiency, true. Okay. So these are the points which I want you to know, sir. Okay. And anything else missing? Next, what else can decrease the acids? A gastrectomy. Gastrectomy. So what exactly is gastrectomy? So gastrectomy means we have removed certain part, okay, certain part of the stomach. We have removed the stomach, sir, gastrectomy. Okay, partial gastrectomy or complete gastrectomy, doesn't matter. The patient, we have removed the stomach. If we remove the stomach, what happens? If we remove the stomach, the amount of acid that's getting produced is going to decrease. If the amount of acid that's going to get produced is going to decrease, the conversion of Fe3 plus into Fe2 plus automatically decreases. Okay, so automatically iron deficiency. So these are the causes of iron deficiency, sir. Okay. Next, if the person is having iron deficiency, already I have explained you, sir, iron is not there. Without iron, can you produce heme? Sir, what is heme, sir? Heme is made up of iron and protoporphyrin. Now iron is not there. Without iron, you cannot produce the heme. Heme is not there. Without heme, can you produce hemoglobin? No, sir, hemoglobin production goes down. So whenever you are having less hemoglobin, small size RBCs are enough. The RBC size will automatically decrease. So that will cause microcytic anemias. Okay, that will cause microcytic hypochromic anemias. Microcytic hypochromic. Why in the name hypochromic? You know it. Because the pale color RBCs. Now, how can we know that the patient is having iron deficiency anemia? So female is going to come to the clinic and she is going to say, sir, I'm having the same symptoms, weakness, okay, nausea, like lightheadedness, vertigo, easy fatigability, all these things she is going to say. If you look at the labs, okay, labs are, okay. So when you look at the labs, what are the changes that are going to be seen? So what about the ferritin levels? Iron deficiency. So iron deficiency, you know, So the stores of the iron, the iron bank, the ferritin, okay, the store of the iron, ferritin levels automatically goes down. Okay, ferritin levels automatically goes down. One thing. Second thing, what I want you to know is, what about the total iron binding capacity? Total iron binding capacity, TIBC. So this TIBC, it's nothing but it's representing total iron binding capacity. Who will bind with the iron, sir? Who will bind with the iron? It's the transferrin. Transferrin binds with the iron. So TIBC, we are talking about, here I am talking about the ferritin levels. I am talking about the ferritin level, sir. So in my body, iron stores are going down. Okay, the iron stores are going down. So what my body will try to do? My body will try to get more iron. Somehow my body will try to get more iron, sir. So my body is increasing the number of carriers. Okay, my liver is increasing the number of carriers. Sorry. Sir, this TIBC, here it represents transferrin. Okay, transferrin, sir. That's my mistake. Okay, so I'm talking about the transferrin. Who is going to bind with the iron? It's the transferrin. Okay, so transferrin are the carriers. So whenever the stores of iron, whenever the iron stores are going down, okay, whenever the iron stores are going down, body will try to get more iron by somehow. So body is increasing the levels of transferrin molecules. More transferrins are there, so that at least more transferrins will bring more iron. If there is some amount of iron there in the JT, you can get it. Okay, so remember, always these two things go opposite. Whenever ferritin levels decreases, TIBC levels increases. Okay, next, what else you should know, sir? So these patients, ferritin levels decreases, TIBC increases. What about the serum iron? Iron in the serum. Okay, iron in the blood, not in the stores. Serum iron. Sir, it's just the iron deficiency. So serum iron also goes down. So the amount of iron which is present in the serum iron also goes down. So ferritin goes down, TIBC increases, serum iron decreases, sir. Okay, these are the points which I want you to know. Apart from this, in the labs, what you can say is, sir, RDW. Okay, RDW, red cell distribution width. Okay, red cell distribution width is going to increase, sir. So what is this RDW and why it is increasing? So first, let me ask you, sir, iron stores are going to decrease gradually or going to decrease suddenly at a time? Iron stores will come gradually down. Okay, iron stores are going to decrease gradually with time. One RBC can live up to 120 days, sir. Okay, one RBC can live up to 120 days. That is almost 4 months. 4 months. So initially, when iron is going down, RBC size is decreased. Within next month, RBC size is little more decreased. In the third month, RBC size is little more decreased. So if you look at the blood, okay, if you look at the blood smear, there are different sized RBCs. Different sized RBCs are going to be seen. So red cell distribution width, the sizes of the RBCs are going to be greatly vary. So that's why red cell distribution width increases. Different sized RBCs. Different sizes. Okay, different sizes of RBCs are going to be seen. So this is one thing. Next, what about the free protoporphyrin? What about the free protoporphyrin, sir? Now some students will get it out. Sir, what is this free protoporphyrin? It will also be elevated. It will also be elevated. First of all, what is it and why it is getting elevated? See, I have explained you, sir, who is going to bind with the protoporphyrin? See, sir, heme is nothing but, okay, heme, it is nothing but iron and protoporphyrin. Okay, heme is nothing but the protoporphyrin ring in which the central iron is there. Okay, so heme is a combo of iron and protoporphyrin. Now in our condition, what about the iron, sir? Iron is deficient. Iron nahi hai. Iron is not there. When iron is not there, what about the protoporphyrin? Protoporphyrin is freely available within the cells. So free protoporphyrin levels in the cell increases. The levels of free protoporphyrin levels, the free protoporphyrin levels are going to increase. So that's why in iron deficiency anemia, the patient are going to have decreased ferritin, TIBC levels increases, serum iron levels decreases, red cell distribution width and free protoporphyrin levels are going to increase. Now one more parameter which I want you to know, which the one more lab change, that's the percentage saturation. Percentage saturation. Okay, so what is this percentage saturation? What you have to know? Say transferrin molecule, one transferrin molecule. See, for example, this is transferrin molecule. Let's take this as a transferrin molecules. Okay. This is the transferrin molecule, sir. Now this transferrin molecule, okay, now it is binding with iron. So it is binding with iron. Okay, it's binding with iron, sir. It can bind with many irons. Okay, it can bind with many irons, sir. Almost it can bind with 6 irons. Okay, but it is not binding with all the irons. Okay, it can bind with all the iron, but it's not binding. Okay, usually the percentage saturation is going to be somewhere around 33%. Okay, the percentage saturation is going to be 33%. Okay, in our condition, see, in our condition, tell me, iron is there? Iron is not there. So iron nahi hai, sir. Iron is not there. Okay, not enough iron is there, I should say. Not enough iron is there. So what happened to the percentage saturation? What happened to the saturation of the transferrin? What happened to the saturation of this transferrin, sir? Saturation goes down. So percentage saturation decreases. Okay, percentage saturation decreases. So that's the one point which I want you to know. Okay, these are the labs. Now what's the treatment? So before treatment, I have to tell you one more condition where there is iron deficiency, sir. One more condition where there is iron deficiency. So there is a condition called as Plummer-Vinson syndrome. Very important for the exams, especially for the board exams and like the FMG exam. The Plummer-Vinson syndrome. What is this Plummer-Vinson syndrome? This Plummer-Vinson syndrome is also called as Patterson-Kelly syndrome, sir. It's also called as Patterson-Kelly syndrome. In this Plummer-Vinson syndrome, the patient is going to have three features. Three features are going to come together in Plummer-Vinson syndrome. Why I am discussing Plummer-Vinson syndrome here is because the Plummer-Vinson syndrome patients are going to have iron deficiency anemia. So iron deficiency anemia, what is one more cause? Plummer-Vinson syndrome. The iron deficiency anemia is going to be seen, that is microcytic anemias. Next thing what is seen is esophageal webs. Esophageal web. Okay, there is webbing in the esophagus. There is a webbing. Okay, so for example, if this is the lumen of the esophagus, imagine. Okay, this is the lumen of the esophagus, sir. In the esophageal lumen, you are having a webbed structure. Okay, there is a webbed structure that is present, sir. For example, something like this, a webbed structure. Esophageal web is going to be present within the lumen. So esophageal web, and last one is angular cheilitis or atrophic glossitis can be seen. Okay, atrophic glossitis. Atrophic glossitis. The patient is going to have a large red beefy tongue. Okay, large red beefy tongue is going to be seen. So at the end of the day, the only point which I want you to know for your exams is, so Plummer-Vinson syndrome, it is associated with iron deficiency. Okay, associated with iron deficiency anemia, sir. Okay, so I have explained you here what are the causes. Any hemorrhage can lead to iron deficiency anemia. Okay, next, what are the laboratory changes that are seen? I have explained you. So what is the treatment that is done, sir? It's a simple supplementation of the iron. Okay, iron supplementation, that is the ferrous sulfate tablets. The treatment is ferrous sulfate tablets. Okay, ferrous sulfate tablets are given. Yeah. The first type of microcytic anemia is completed. What is the first type? Iron deficiency anemia. So after iron deficiency anemia, now let's discuss about the second type of anemia, sir. The second type of anemia that now I am going to discuss is anemia of chronic disease. First, let's discuss about the anemia of chronic disease. Later, I will discuss about the other two, sideroblastic anemia and thalassemia. Okay? So now let's discuss about anemia of chronic disease. So anemia of chronic disease. So if there is any chronic condition, so the patient is having some chronic condition, for example, like autoimmune disorder. Okay, autoimmune disorder or any chronic infection. Okay, the patient is having chronic infections. Okay, usually more than 6 months. The chronic infections, chronic autoimmune disorders, or the patient is having cancers. Patient is having cancers. Now, in all these are the examples of chronic diseases. Okay, now in all these chronic conditions, okay, and one more thing, usually the question is going to come something like the patient is usually hospitalized. Okay, in the hospitalized patients, like the chronic patients. Okay, so hospitalized patients. Hospitalized patients. So in these patients, do you know acute phase reactions are going to be produced? One acute phase reactant is going to be produced. Okay, via the liver. Whenever there is chronic inflammation in the body, the liver is going to produce a protein which is called as hepcidin. Hepcidin, sir. Now, do you know what is this hepcidin going to do? Sir, hepcidin is always against iron. It's always against iron, sir. So, hepcidin, what it will do is it decreases the iron levels in the body. Okay, it decreases the iron levels, or I should say it decreases the iron absorption. Okay, decrease the iron absorption, and all the iron whatever is there in the blood, okay, all the iron whatever is there in the blood, that will be packed inside the bone marrow and will be packed inside the liver. So now iron is not freely available anywhere. Why it is happening? Because the iron is one of the most important substance for the bacteria, for the bacterial growth, iron. So our body is thinking something like, sir, there is some infection going on in the body, so we should not give the food for the bacteria. The iron is acting like a food, sir. It's very important for the bacterial, like, growth. So all the iron is packed inside the bone marrow or the liver. So now iron is not there outside anywhere. Anywhere iron is not available, sir. Iron is there in the body, but it is not available for hemoglobin synthesis because iron is totally packed within the liver. Iron is not coming out. Iron is not available for the synthesis of hemoglobin. Okay, so iron level. So this is the iron anemia of chronic disease. So anemia is going to be seen in a patients who are having chronic diseases or chronic inflammations. Okay, so if you look at the labs, okay, if you look at the labs, so how the labs are going to be? What about the ferritin? Sir, is this any deficiency of iron? Is there any deficiency of iron? No, sir. Even ferritin levels actually increases because all the iron, whatever is in the serum, all the iron, whatever is freely there, all that iron is now packed inside the liver and bone marrow. So ferritin levels are going to be more. Sir, if more ferritin is there, means already you are having more ferritin, sir. So what happened to TIBC? That is transferrin levels, the carrier molecules. You are having sufficient amount of iron. When you are having sufficient amount of iron, what happened to the TIBC? TIBC goes down. Simple. Transferrin molecules level goes down. Right now, you don't want any carrier molecules. You don't want iron. So TIBC is going down. Next, what happened to serum iron? So serum iron. I have said you, all the iron is going to be packed. So serum iron also decreases. What happened to percentage saturation? The percentage saturation also decreases, sir. Everything decreases. Okay, percentage saturation is also going to decrease. Okay, so this is the point which I want you to know. It's the, who is the culprit, sir? Here the culprit is hepcidin. Okay, in anemia of chronic disease, chronic inflammatory conditions, cancers, autoimmune conditions, liver is going to produce a molecule which is called as a hepcidin. Hepcidin inhibits iron absorption. Hepcidin inhibits iron absorption, true. Also, hepcidin inhibits erythropoiesis, EPO, erythropoietin production, EPO production. Okay, so no erythropoiesis, no hemoglobin synthesis, that can lead to anemia of chronic disease. Okay, that can lead to anemia of chronic disease. So, in this condition, what happened to ferritin levels? Ferritin levels are going to be more, TIBC levels are going to be less, serum iron is going to be less, percentage saturation is going to be less. Okay, what about the free erythrocyte protoporphyrin? The erythrocyte free protoporphyrin. Sir, free protoporphyrin levels. Again, in this condition also, see, iron is not available, sir. Iron is not available for the hematopoiesis or for the hemoglobin synthesis. Iron is not available. So when iron is not available, tell me what happens. Sir, iron nahi hai to, if iron is not there, okay, iron is not there. So protoporphyrin is going to be free. Okay, iron should go and bind with the protoporphyrin. When iron is not there, the protoporphyrin is free, sir. So free protoporphyrin levels within the cells are going to be more. Okay, more. So done, completed. Okay. Next, what else I have to teach you is, sir, if you look at the RBCs under the microscope, what your logic says you? Sir, this anemia of chronic disease, you have taught anemia of chronic disease under microcytic anemias. Microcytic anemias. So RBC size is going to be less, right? RBC size should be less than 80 femtoliters. But most of the time, say RBC size will be normal. The RBC size is normal. So anemia of chronic disease, yes, of course we are discussing under microcytic anemias, but if you look the size of the RBCs, they are normal. So they are normocytic. Okay, normocytic anemias. So tell me, sir, if they ask you anemia of chronic disease, is it a microcytic anemia or normocytic anemia? The best answer is going to be a normocytic anemia. Though, yes, I know I have discussed it under the microcytic anemias, but most of the time the RBC size will be maintained normal. So it's a better example under normocytic anemia, sir. Okay, so what's the treatment? You have to simply address the underlying cause. Just address the underlying cause. What's the wrong with this patient? Okay, so why the chronic inflammation is there, or why the chronic infection is there? Okay, what is that autoimmune disorder? You just try to address the problem. So second type of anemia is also completed, sir. Now the third anemia that I'm going to start, third microcytic anemia that I'm going to start is sideroblastic anemia. Sideroblastic anemia. So, what is this sideroblast? Sidero means iron. Sideroblastic anemias. See, in the sideroblastic anemia, what is the problem? So, decrease protoporphyrin. Decrease protoporphyrin, sir. Okay. So, when protoporphyrin is not there, see, protoporphyrin have to bind with the iron and forms heme. Now, protoporphyrin is not there, sir. So, what happened to the heme, sir? Heme also decreases. When heme is not there, so when heme is not there, do you think hemoglobin will be there? No hemoglobin. No hemoglobin. So if hemoglobin is not there, that causes microcytic anemia. Okay, MCM, microcytic anemia, sir. Okay. Now, what I want you to know here is, sir, how the protoporphyrin is synthesized. Okay, how the protoporphyrin is synthesized. Let me show you. Sir, look here. These are the different stages in which the protoporphyrin is synthesized. At the end of the day, look, protoporphyrin is synthesized. The protoporphyrin is going to bind with the iron. The protoporphyrin is going to take the iron and forms heme. Okay, it forms heme, sir. Okay. Now, the most important point is, in the production of protoporphyrin, what do you need? Enzymes. Which enzymes? ALA synthase. Okay, ALA synthase, sir. This is an enzyme. Amino levulinic acid synthase. Okay, amino levulinic acid synthase, ALA synthase. This enzyme is liquid, and ALA dehydratase. Okay, ALAD. See, this is ALAS, ALAS, ALAD, ALAD. So this ALAS and ALAD, these are the enzymes which are very much important in the production of protoporphyrin. Sir, if these enzymes are deficient, sir, or these enzymes are inhibited, these enzymes are not functioning, at the end of the day, protoporphyrin is not going to be produced. If protoporphyrin is not produced, no heme. Iron is going to be free within the cells. Iron is freely present within the RBCs. Iron is freely present within the cells. Iron causes damage to the cell. Simple. So iron is accumulating within the cell. Iron is accumulating within the cell. So this iron loaded cell is called as sideroblast. Sideroblastic anemia. So let's write one by one. What are the problems that what is the problem that is seen in the sideroblastic anemia? Let me write here, sir. See, sideroblastic anemia, this amino levulinic acid synthase, that is the ALAS, these enzymes. Okay, ALAS, ALAS and ALAD. These are the most important enzymes in the production of the protoporphyrin. Okay, protoporphyrin. And one more enzyme is there which is called as a ferrochelatase. Okay, ferrochelatase. Sir, where is this ferrochelatase? We haven't seen this ferrochelatase. Now just wait, look here. Sir, the last step, sir. Okay, the last step. The ferrochelatase is the one which helps in binding iron and protoporphyrin. Iron and protoporphyrin, they will fuse and forms heme, sir. It will form heme. So if this ferrochelatase, again, if it is also defective, that will also cause sideroblastic anemia. Free iron is going to be there, that will cause sideroblastic anemia. So let's write one by one. See why these enzymes are important. Let me tell you. So in most of the cases, there is deficiency of this enzyme, ALAS deficiency by birth itself, congenital deficiency of ALAS. Okay, congenital deficiency of ALAS, sir. Now, what else? Sir, lead poisoning. There is something called as a lead poisoning. The lead poisoning, alcoholism. The lead poisoning, alcoholism, they will cause Okay, they will cause deficiency of this enzyme. Okay, lead poisoning, if lead poisoning is there, LAD is going to be affected. So congenital deficiency of LAS can be seen. And for the functioning of this amino-levulinic acid synthase, see, for the functioning of this amino-levulinic acid, levulinic acid synthase, what do you require? You require vitamin B6. B6 is required. So if the B6 is deficient, this enzyme is not going to function. That enzyme is not going to function. If that enzyme is not functioning, protoporphyrin is not produced. If protoporphyrin is not there, heme is not there. If heme is not there, hemoglobin is not there. So that will cause microcytic anemias. So what are the causes of this sideroblastic anemia? The causes of sideroblastic anemia are, sir, B6 deficiency can cause it. Lead poisoning can cause it. Alcoholism can cause it. Okay. So these are the important causes. Important causes are B6 deficiency, lead poisoning and alcoholism. They will also affect ferrochelatase. Sorry, excuse me, sir. So now in this condition, sideroblastic anemia, tell me what happens. Protoporphyrin is not there. Why protoporphyrin is not there? These enzymes are either deficient, they are stop functioning. Okay. Now if this protoporphyrin is not there, what happened to the iron? Iron is freely available. More iron is getting accumulated within the RBC. So those iron loaded RBCs are called as ringed sideroblasts. This is the RBC, sir. This is actually RBC. Okay. Now in the RBC, see, there is a iron accumulation. There is iron accumulation, sir. Okay. So this is an actually immature cell. Okay, immature cell. The patient is having severe anemia. The patient is having anemia, so that the immature cells are coming into the circulation. The immature cells are coming into the circulation, sir. Normally within the RBC, you are not supposed to see any nucleus. You are not supposed to see any nucleus. So now these are the nucleated RBCs. These are the nucleated RBCs, sir. The nucleated RBCs are coming into the peripheral, stream, because the patient is having severe anemia. So in order to counteract that anemia, the immature RBCs are coming into the blood. That too, these immature RBCs, see, they are loaded with the iron. Lots and lots of iron is there, freely available in the cytoplasm. Why the iron is freely available? Why? Because protoporphyrin is not there. No one is accepting the iron. Okay, no one is accepting the iron, sir. So iron is freely available. So I have said you, iron is a free radical. What iron will do? Iron will cause damage to the cells. Iron will cause damage to the cells. RBC lysis. First of all, they are immature RBCs, and again upon which the RBCs are going to be destroyed. So when the RBCs are destroyed, what happened to all this iron? Iron will leak into the blood. Iron is now freely leaking into the blood. So this iron is causing the damage to the RBCs. So this damage to the RBCs will cause the leak of iron into the blood. So iron levels in the blood increases. So let's write one by one. So what are seen in the labs? In sideroblastic anemia, what is seen in the labs? The labs may. So what about the ferritin levels? The ferritin levels are going to be more. What is ferritin, sir? Iron. Iron is more available, sir. Why? Because protoporphyrin is not there. Okay, protoporphyrin is not there. So much iron is freely there. No one is using the iron. Freely available, sir. Iron. So ferritin levels increases. So when you have more amount of iron, do you need any further iron absorption? No. So what happened to the transferrin? The transferrin, the carrier molecules goes down. You already have iron, so transferrin goes down. Okay. Next, what about the TIBC? Or let me first say, what about the serum iron? What about the serum iron, sir? The RBCs are dying. So the dying RBCs, the immature RBCs are dying, sir. So from this immature RBCs, iron is going to leak into the blood. Iron is going to leak into the blood. So more iron is going to be there in the serum. So serum iron levels are going to be elevated. The serum iron levels are going to be elevated. If more serum iron is there, what happened to the percentage saturation? Percentage saturation also increases, sir. Percentage sat increases. So more iron is there in the blood. Okay, so this iron will go and bind with the transferrin. Okay, whatever the transferrin are there. Okay, of course transferrin levels decreases. So whatever the transferrin are there, the iron will go and bind with the transferrin. So percentage saturation increases. Okay, percentage saturation increases. So this is how the laboratory values are going to be changed in a patient who is having iron deficiency. Sideroblastic anemia. So sideroblastic anemia, what is the important causes? B6 deficiency. B6. Why B6 deficiency? Because B6 is the cofactor, sir. B6 is the cofactor for the production of this enzyme. Sir, if you want to have this ALA synthase activity, if you want the ALA synthase to function normally, you require B6. So B6 is the cofactor for that enzyme. If this B6 is not there, this enzyme won't function. If that enzyme is not functioning, protoporphyrin is not there. Without protoporphyrin, no heme. Without heme, no hemoglobin, microcytic anemias. Microcytic anemias. Okay, B6 deficiency can cause sideroblastic anemia. Okay, alcoholism, lead poisoning. Okay, alcoholism, lead poisoning, they inhibit the ALAD. Okay, this one, sir, ALAD. Alcoholism, lead poisoning inhibits ALAD. Okay, this alcoholism and lead poisoning will also inhibit the ferrochelatase. At the end of the day, protoporphyrin is not there. Without protoporphyrin, free iron. Free iron means sideroblastic anemia. In one of the exams, this question was asked. See, especially in the Indian exam, this question was asked, sir. See, what is the stain that is used here? What is the stain that is used? The stain that is used here is Prussian blue stain. Okay, because the stain that is used for the iron is pearl stain or Prussian blue stain. Pearl stain. Okay, pearl stain or Prussian blue stain is used for staining the iron. So these are the sideroblast. Okay, so done. What else I should teach you? The sideroblastic anemia can be seen. Let me put it this way. So sideroblastic anemia can be seen in a patient who is having B6 deficiency. Just now I have explained the B6 deficiency can cause sideroblastic anemia because when B6 is not there, aminolevulinic acid synthase is not functioning. If this aminolevulinic acid synthase, if it is not functioning, you know it. So then why the patient is getting B6 deficiency? Why the patient is getting B6 deficiency is because the patient is using anti-tubercular medication. What is that anti-tubercular medication? Isoniazid. Okay, isoniazid. He is using isoniazid, sir. So this isoniazid causes B6 deficiency. So a person who is using isoniazid can become B6 deficient. The B6 deficient, the pyridoxine, the B6 pyridoxine, the pyridoxine deficiency can lead to non-functioning of this enzyme. Aminolevulinic acid synthase enzyme is not going to function without that B6, without that cofactor. So that can lead to sideroblastic anemia. No protoporphyrin, sideroblastic anemia. Okay, so the third type of anemia is also completed. Okay, sideroblastic anemia is also completed, sir. Okay, next, the fourth type of microcytic anemia that I'm going to discuss here. The fourth type, sir. The fourth type is thalassemia. It's a thalassemia, sir. Okay, so the thalassemia is the most common. Okay, the thalassemia is the most common hemoglobinopathy in the world. It's a hemoglobin related problem, sir. Thalassemia is a hemoglobin related problem. So do you know what is the problem with the thalassemia? Sir, in thalassemia, the problem is deficiency of the globin chains. Okay, the patient is having anemia. Why anemia? Because deficiency of globins. Globin is deficient, that's it, not defective. It's not defective hemoglobin, deficiency of the globin chains. Now tell me, how many types of globins are there? How many types of globin chains are there, sir? Alpha globins, beta globins. If alpha globin chains are defective, if alpha globin chains are deficient, that will cause alpha thalassemia. If the beta globin chains are defective, deficiency. If the beta globin chains are deficient, if the beta globin protein is deficient, that will cause beta thalassemia. Okay, alpha thalassemia or beta thalassemia, sir. Okay, alpha thalassemia and beta thalassemia. So how many types of thalassemia are there? Alpha and beta. If alpha chains are deficient, alpha thalassemia. If the beta chains are deficient, beta thalassemia. Okay, actually normally you have two alpha chains, two beta chains. Two alpha chains and two beta chains will be there. Deficiency of alpha chains causes alpha thalassemia, deficiency of beta chains causes beta thalassemia. Okay, so why thalassemia? What is the problem with the thalassemia, sir? It's a hemoglobinopathy. It's a hemoglobin related problem, sir. The most common hemoglobinopathy. What is the hemoglobin related problem? Globin chains are deficient. Globin chains are deficient. So first let's discuss about the alpha thalassemia. Okay, sir, alpha thalassemia. See, in alpha thalassemia, the points which I want you to know is, sir, actually there are 4 alpha genes, sir. Okay, the alpha globins, right? Okay, alpha globin chains are deficient, right? First alpha thalassemia, alpha globin chains are deficient. So quantitative problem, not the quality. Quantity is less, sir. Quantitative problem. So alpha globin chains are deficient. See, for this alpha globin is a protein. there should be genes. So how many genes are there? How many alpha genes are there? There are 4 alpha genes. There are 4 alpha genes. Alpha genes are 4, sir. Alpha genes are 4 alpha genes are there. Okay. So these alpha genes are present on chromosome number 16. Okay, they are present on the chromosome number 16. 4 alpha genes are there. Before going further, I want you to know one more important point. Normally we adults, okay, we have which type of hemoglobin? HbA. Okay, HbA. Also HbA2. There is one more type of hemoglobin called as HbA2. And fetus, okay, fetus during like in the fetal period, fetus is going to have fetal hemoglobin, HbF. Sir, what is the difference between HbA, HbA2 and HbF, sir? What is the difference between different types of hemoglobin? So, adult hemoglobin is made up of 2 alpha chains, 2 beta chains. Just now I have discussed, you know it. So, there are 2 alpha chains and 2 beta chains, 2 types of globins, alpha globins, beta globins, 2 alpha globins, 2 beta globins. In HbA2, 2 alpha chains are there and 2 delta chains are there. 2 alpha, 2 delta, 2 alpha, 2 delta in HbA2. It's also adult hemoglobin, HbA2. In HbF, fetal hemoglobin, sir, alpha 2, gamma 2, sir, alpha 2 and gamma 2. Different type of, like, you know, people in adults and in children. Now, here the point is, sir, what is alpha thalassemia and why it is coming? Alpha thalassemia is due to deficiency of the alpha globin chains. How many genes are there for the alpha globins? So, there are 4 genes for the alpha globins. There are 4 alpha genes. 4 alpha genes. Now, say, sir, if one alpha gene is deletion, sir. Usually, alpha thalassemia is because of the gene deletions. Genes are deleted. If one alpha gene is deleted, do you think will there be any problem? No problems. Asymptomatic. So the patient is usually asymptomatic. Okay, one alpha gene is defective, the patient is going to be absolutely asymptomatic. So if 2 genes are deleted, 2 alpha genes are deleted. If 2 alpha genes are deleted, now alpha globin chain production decreases. The alpha globin chain production decreases. If the alpha globin chain production decreases, mild anemia, sir. Mild? Yeah. A little anemia. Mild anemia is going to be seen. Okay. So, if 3 genes are deleted, what happens? Now, alpha globin chains are not getting produced. Okay. Now, alpha globin chains are not going to be produced. If alpha globin chains are not getting to be produced, what's the only chain that's left over? Beta chains. Beta chains are there. There is no problem with the beta chains. Now, normally alpha chains and beta chains will be together. Alpha chains bind with the beta chains. Okay, alpha and beta chains are going to be together, sir. Now, when alpha chains are not getting produced because of the 3 genes are deleted, so alpha gene production, the alpha globins production is going to be very much deficient. Now, it's only beta genes and beta globins are there. Only beta globulins are there. Okay, beta globulins are there. Now, only beta globulins are going to be bind with the beta globulins. So, this forms tetramers of beta globulins. So, now if 3 genes are deleted, that forms beta chains. The beta chains are going to form tetramers. Okay, beta chains. Only beta chains are there now. It should be 2 alpha, 2 beta. Tetramer. 2 alpha, 2 beta. Now, only beta are there. So, that causes beta chain tetramers. Okay, all are beta chains. Beta, 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 beta. Now, 4 beta chains. So, this type of hemoglobin where beta tetramers are seen, this is called as HbH. What is HbH? So, HbH is nothing but, so the patient is having deletion of 3 genes where there is severe anemia and the patient is having which type of hemoglobin? HbH. HbH means tetramers of beta are there. Okay. So, now this HbH, this type of hemoglobin is going to cause damage. It's going to cause damage to RBC. So, RBCs are going to be undergoing lysis. Okay, RBCs will undergo lysis, that causes anemia, sir. If 4 genes are deleted, see 4 alpha genes are deleted, 4 genes are deleted. If 4 genes are deleted, tell me, there is no alpha globin chain at all. From the birth itself, or I should say in utero itself, so the baby is not having any alpha genes, all alpha genes are deleted. If all alpha genes are deleted, the baby cannot produce any alpha globin chains. Sir, during intrauterine life, what type of hemoglobin is there? Hemoglobin F is there. Hemoglobin F also, see, it have 2 alpha globin chains. Now, Do you think the baby is going to produce this alpha globin chains? No, sir. Alpha globin chains are not going to be produced. If alpha globin chains are not produced, means only gamma chains are there. So only gamma chains are going to be there in utero life. These gamma chains are going to form tetramers. These gamma chains are going to form tetramers, sir. So if 4 alpha genes are deleted, means, right, deletion of 4 genes will cause gamma tetramers. These are called as hemoglobin BARTs. This type of hemoglobin is called as hemoglobin BARTs. So this is not compatible with life, sir. The baby is going to die in utero itself. The baby is going to die in utero itself. That's called as a hydrops fetalis. The hydrops fetalis. So the baby is going to die with severe anemia. So hydrops fetalis. Okay. So 1 alpha gene deletion, not a problem. 2 alpha gene mutation, deletion, mild anemia. 3 alpha gene mutation, or I should say that 3 alpha gene deletion. The 3 alpha gene deletions can cause HBH, and 4 alpha gene deletions is not compatible with life, that is death in utero because of hydrops fetalis. Okay, hydrops fetalis. Okay, so alpha thalassemia is completed, sir. Alpha thalassemia is completed. Okay, now after alpha thalassemia, what is the next variety? Beta thalassemia. Okay, beta thalassemia, sir. So what is the beta thalassemia? What is the problem? Sir, actually there are 2 genes for beta globin. Okay, there are 2 genes for beta globin, sir. Okay, there are 2 genes for beta globins. Okay, now when these genes are mutated, not deleted, mutated. Okay, when the genes are mutated, what happens? Gene mutation. So gene mutation. So there is deficiency, again not defect, deficiency in beta globins. So simple, sir. Gene mutations. 2 types of genes are there. Not 2 types of genes. 2 pairs of 2 genes are there. 2 genes. Okay, not 2 pairs also. 2 genes are there. 2 beta genes. Okay. So gene mutations can lead to deficiency of beta globins. If beta globins are deficient, that causes beta thalassemia. Beta thalassemia. Now let me put it this way, sir. These are the normal beta genes. Beta, beta. This is something normal. 2 beta genes are functional. Both are functional, sir. Okay. Now, what happens? See, if the mutations are something like this, right? See, tell me, we are having how many beta genes? 2 beta genes, one from the mother, one from the father. Okay. Now, one beta gene is normal. One beta gene got mutated. One beta gene got mutated, sir. Now, mutated means now it is going to produce. See, this beta plus. What is this beta plus represent? It represents. Okay, beta plus it represents something like deficiency of globin. Now it's going to, yes, it's still working. It produces less beta globin. It codes for less beta globin. Now there is something called as beta naught. Beta naught means complete absence. It's not going to code for any protein. It's not going to code for any protein, sir. Zero production, zero. It's not going to produce any protein. Okay, so the patient can have beta and beta naught. Now let's make it a little bit more problematic. Now, what if the patient is having both the beta genes, beta plus, means both are mutated, both are going to produce deficient globin chains. Now let's make it more worse, sir, more worse. The beta naught means both complete absence. They are not at all coding for, okay, they are not at all coding for any beta globins. Okay, they are not at all coding for any beta globins. Complete, very severe, most severe condition. So how many combinations are possible? There are 4 combinations possible, sir. See, let's take the extremes. Let's check about the extremes. So one is this one. One is normal, other is little affected, So this is called as minor, beta thal minor. A minor problem. Why? Because one gene is normal, it's coding for normal beta globins, and other gene is little affected, so it's causing deficiency in the beta globins. Okay, little deficiency in the beta globins. And last one, sir, complete absence. Beta globins are not getting produced. Okay, this is a more severe condition, sir. This is a more severe condition. This is the milder condition. See, beta thal minor is a minor condition. Beta thal major is a more severe condition. So this is called as beta thalassemia major. Okay, beta thalassemia major, it's a severe condition. Okay, so now let's see about the beta thalassemia major now. First, let's discuss about the beta thalassemia major, or we can discuss about anything. First, let's discuss about the beta thalassemia minor. What is the problem in beta thalassemia minor? The problem in beta thalassemia minor is one is normal. One beta globin gene is absolutely normal. The other beta globin gene is little affected. Little affected. So now what are the symptoms, sir? The symptoms are going to be mild anemia. Okay, mild anemia. Okay, not a serious problem. Mild. The patients are going to have mild anemia, sir. Okay, beta thalassemia minor. See, now these patients, okay, beta thalassemia minor. So these patients are going to have, how to identify that the patient is having a beta thalassemia minor, sir? So this patient is having beta thalassemia minor. How can we say? There's going to be some small changes in other types of hemoglobin. Okay, so what is that? Say in beta thalassemia minor, the patient is going to have decrease HbA, normal hemoglobin HbA. The HbA levels are going to reduce. Then there is no doubt the HbA levels are going to decrease, sir. Slightly decrease, not much, slightly decrease. But the other types of hemoglobins are going to compensately, like they are going to rise as a compensatory action. Okay, one type of hemoglobin is deficient, no. So other types of hemoglobin are going to rise. What happens in this condition is HbA2 levels are going to rise. Okay, are going to rise. They are almost getting double. The normal levels of HbA2 is 2.5%. Normal HbA2 level will be 2.5%. Now it becomes 5%. Okay, HbA2 levels will increase. Not only that, the HbF levels are also going to increase. HbF levels are also going to increase. So how to identify that the patient is having beta thalassemia minor? The patient is having mild anemia, sir. But when you do hemoglobin electrophoresis, okay, hemoglobin electrophoresis, you can see different types of hemoglobins. So the patient is going to have decreased HbA, but with increased HbA2 as well as HbF. This is the point which I want you to know. So usually these patients are not requiring any blood transfusions. They don't require any blood transfusions, sir. Usually they're carrying on with their life. Okay, normal life. But what about the major, sir? Beta thalassemia major. Beta thalassemia major. So this is more serious condition. These patients will die if you don't give blood transfusions. They are surviving only on blood transfusions. Okay, they're only surviving on the blood transfusion. So without blood transfusion, they will die. So every week or for every 10 days they have to go and they have to take the blood transfusion continuously. Okay. The point which I want you to know here is in beta thalassemia major. So it's a more severe disease. Okay. See, if the beta genes are not there, the beta genes are not there, sir, now. Or I should say the beta genes are mutated. Both the beta genes are mutated. So that is beta naught. Beta genes are mutated. When the beta genes are mutated, the beta globin chains are not going to be produced defective, or I should say deficient. Okay, deficiency of the beta globin chains. When the beta globin chains are deficient, now beta globin is not there, sir. Who is only there? Alpha globin is there. So what happens? The alpha globin chains are going to fuse. Okay, everywhere is the alpha globin, the 4 alpha globin chains. So alpha globins form tetramers. Alpha chains form tetramers. Alpha chains will form the tetramers. Okay, so this is the one point which I want you to know. So these alpha chains are going to form tetramers, and these alpha tetramers are going to precipitate and they will cause the damage to the RBCs. They will cause the damage to the RBCs. The RBCs are going to undergo extravascular hemolysis. Okay, the RBCs are going to undergo extravascular, sometimes even intravascular hemolysis can occur. Okay, so these alpha chains, they will precipitate and they will form. Okay, these alpha chains, they will precipitate and they will cause the, let me put it this way, the alpha chains will precipitate and cause damage. They cause damage where? Of the cell membrane of the RBC. cause damage to the cell membrane of RBC. The RBC cell membrane is going to be damaged because of this unpaired alpha chains. Okay, so that causes damage to the RBC cell membrane. Okay, RBC cell membranes. So whenever the RBCs with the damaged cell membranes are seen in the spleen is going to immediately destroy those RBCs. This is a damaged RBC, so let's destroy it. So extravascular hemolysis will occur. The next important point with the beta thalassemia, which I want you to know is, sir, the babies is not going to have any problem. Babies in the first 6 months, no symptoms. No symptoms. Why? Because you know, sir, in utero also no problem. In utero also no problem. Beta thalassemia major, because in utero, what kind of hemoglobin is there, sir? HbF hemoglobin is there. HbF hemoglobin is there. What is HbF? Alpha 2, gamma 2. Alpha 2, gamma 2. There is no such thing as beta. Okay, there is no such thing as beta chain. So, beta thalassemia major babies, the beta thalassemia major babies, when they are in utero, they do not have any problem because there is no concept of beta. Okay, there is no point of the beta chain. So, they are absolutely normal. But after taking birth, what happens? After the 6 months, the first 6 months also same, fetal hemoglobin is dominant. So, by 6 months, what happens? So, by 6 months, the fetal hemoglobin is replaced with adult hemoglobin. Fetal hemoglobin is replaced with the adult hemoglobin. So, fetal hemoglobin, okay, but these babies do not have beta chains. These babies do not have beta chains. As they are not having beta chains, okay, these babies are not having beta chains, sir. Only alpha chains are there. Okay, so symptoms will start to appear after, 6 months. First 6 months, they are surviving. After 6 months, they will be having problem. So what is happening? The alpha chains will precipitate. Alpha chains will cause damage to the cell membrane. So damaged cells, damaged RBCs are going to get broken down the spleen. So that's the extravascular hemolysis that's going to occur, sir. Extravascular hemolysis are going to occur. So these patients are having very severe hemolysis. Because beta thalassemia patients are going to have very severe hemolysis. So lots and lots of hemolysis, sir. Breakdown. Lots and lots of hemolysis occurring. So what my body will try to do? My body will try to compensate. So how my body is compensating? Now, till now, the RBC production, till now, the RBC production is happening in the bones, long bones in the body. Now, in order to produce more RBC, the hematopoietic activity will also start to occur in the flat bones, Now, there is extramedullary hematopoiesis that's going to occur. So, in this condition, beta thalassemia major, there is going to be extramedullary hematopoiesis. Sir. Okay, so where hematopoiesis, now the hematopoiesis is happening even in the skull bones. Okay, hematopoiesis is extended to the skull bones. So that's why in these patients, okay, if you look at their face, so their face, because of this extramedullary hematopoiesis, the thickness of the bones increases. Their face is going to look like a lion-like faces. Okay, lion-like faces are going to be seen in beta thalassemia major. True. Okay, lion-like faces are going to be seen. If you take an X-ray, see how the skull is going to look like. So all these spikes, they are representing extramedullary hematopoiesis. This is called as crew-cut appearance. So crew-cut appearance is seen on the X-ray. Crew-cut appearance is because of the extramedullary hematopoiesis. Okay. Next, what else? Sir, more RBCs are getting destroyed, right? Because of the alpha chain precipitation. Alpha chains will cause the damage to the cell membrane. So whenever the damaged cells are there, the cells are dying. Usually RBC destruction happens where, sir? In the spleen. But more cells are dying. So now this destruction of the cells are also happening in the spleen as well as the liver. So now they are doing more work. Breaking down the RBCs. So the patients are going to have hepatosplenomegaly. So the patients who are having beta thalassemia major, they are having, yes, extramedullary hematopoiesis. True. Because of that, they are going to have lion-like faces. Okay, lion-like faces or chipmunk-like faces. Okay, chipmunk-like faces or lion-like faces. Lion-like faces or chipmunk-like faces. And one more thing, on X-ray, what you will see? The crew-cut appearance. Okay, crew-cut appearance is seen on the X-ray. Crew-cut appearance. Okay, or that crew-cut appearance is also called as hair-on-end appearance. Okay, hair-on-end appearance can be seen on the X-rays. That's also possible. So more RBC breakdown is happening in the reticuloendothelial system. So there will be hepatosplenomegaly, hepatomegaly and splenomegaly. Okay, so there can be hepatomegaly as well as splenomegaly, sir. Now, if you do electrophoresis, HB electrophoresis, what can be seen? Sir, how to identify beta cell major? This is the case of beta cell major. Do you know what happens? Sir, HB electrophoresis, so no HbA, little to no HbA, sir, no HbA, no HbA, hemoglobin A is absent. Why hemoglobin A is absent, sir? Hemoglobin A is made up of 2 alpha, 2 beta. Beta is not there. Beta is not there. That's not a hemoglobin A. So hemoglobin A is not there. Now what else is there, sir? So the patient is going to have HbA2 levels and HbF levels. They are elevated. So HbA2 and HbF levels are going to be elevated, sir. Okay. So definitely it's a microcytic anemia. Hemoglobin production is not there, sir. Hemoglobin production, the beta globin chains are not there. So less hemoglobin, so small size RBCs. So microcytic hypochromic RBCs are going to be seen. Especially in this condition, the patients are also going to have something like this. Let me show you. So these patients with beta thalassemia major, they will have this kind of RBCs, sir. So what are these RBCs? These are target cells. These are target cells. They are looking like a bullseye, right? Bullseye or target cells. So why target cells? Is because, see, the RBCs, first of all, they are small in size. What about the hemoglobin inside the RBCs? What about the hemoglobin, amount of hemoglobin inside the RBCs? Now less hemoglobin. Now when there is less hemoglobin, now RBC membrane is not going to be stiff, sir. Let's put it this way, like, in an easy way to understand. So now the hemoglobin is not going to be there. Deficiency of the hemoglobin. When less hemoglobin is there, now RBCs are going to become very loose. Hemoglobin is not there. They are not going to be stout. They are not going to be stiff. Now inside the cell, the hemoglobin is very less. So the membrane is going to be very much loose. So now the RBC membrane will become something like this. For example, say normal RBC membrane, it's like this, sir. So inside what is there? Hemoglobin. Good amount of hemoglobin is there. Good amount of hemoglobin is there. Okay. In the periphery, you are going to have more hemoglobins. Okay. Like this. But what happens in beta thalassemia? There is severe deficiency of the hemoglobin. So RBC is going to become, like, in the membrane is going to become loose. So that loose membranes, the loose RBC membranes can form blebs like this. They can form what? Can form blebs. Cytoplasmic blebs. Okay, the cell membrane blebs. Okay, they are forming the blebs. Now some amount of hemoglobin will come and get deposited over here. Some amount of hemoglobin. So yes, hemoglobin is there in the periphery. Okay, but some amount of hemoglobin will also come and get deposited in the center. So now the center also you can see that red color. So that's why, sir. Okay, so target cells can be seen. Target cells can be seen, crew-cut appearance, the chipmunk faces or lion-like faces can be seen, extramedullary hematopoiesis. Okay, that completely dependent on the transfusions. Completely that dependent on the transfusions, sir. Without transfusions, they won't live. So there is no problem during the childhood, or I should say there is no problem before the 6 months. Okay, in utero and 6 months, no problem. After 6 months, when the fetal hemoglobin is getting transitioned into the adult hemoglobin, then comes the problem. Then comes the hemolysis. Okay, these are the problems, sir. And what else I want you to know is that these patients who are having beta thalassemia major, okay, these patients who are having the beta thalassemia major, they are continuously taking the transfusions from outside. They are taking the normal RBCs, the blood transfusions. Okay, they are like blood vampires. They are drinking the blood. Okay, they are always every, like, for every 10 days, 12 days, they are going and taking the blood transfusions, which means they are simply taking the iron from outside. Blood, they are taking the blood, sir, from outside. They are taking the blood. So every time they are loading their body with more and more iron. Blood is nothing but the iron. Blood have hemoglobin. Hemoglobin have heme. Heme have iron. So they are taking the iron into the body. So these patients are at a risk of developing hemochromatosis. So what is the risk, sir? So these patients are at a risk of hemochromatosis. These patients are at risk of developing hemochromatosis. That is iron overloaded state. Iron overloaded state. So these are some important points regarding the thalassemia. So remember, the thalassemia is not a qualitative problem. It's a quantitative hemoglobin defect. Quantitative problem, which means alpha globin is deficient, alpha thalassemia, beta globin deficient, beta thalassemia. Okay, so done, sir. Microcytic anemias are completed. I hope this will be enough for today. in the tomorrow's class, let's continue with the macrocytic anemias and normocytic anemias in the tomorrow's class. Hope the class is helpful. See you tomorrow. Thank you.